He's a member of the British Geriatric Society and the Royal College of Physicians, and I know, because we had a sneak preview of this in another place, that he's going to give a very informative and educational talk this evening. James.
Thank you very much, Liz, and thank you very much for inviting me to present tonight. And thank you all for staying and coming to listen to me. So I've got a 20-minute presentation just to give you an idea. And it's a view from me as a geriatrician and a consultant physician who does medicine and elderly care, an overview, and also I've been dementia lead for a few years until a few months ago, so I've been very privileged to be part of the improvements and developments within the acute hospital with regards to dementia care. I'm going to cover these areas briefly: why it's important, how do we recognise it, what we can do about it as a disease, what the challenges of dementia are as a condition, and what has been done, just a bit of flavour of what we've done at Hampshire hospitals, and a little bit about the future. So, why is it important? Well, we often hear about, from a national perspective, about how it's important in society. There's so many people with dementia and it's increasing, but actually if we take it from the individual's point of view, the person that actually has dementia, develops dementia, it doesn't matter whether it's common or not. It's that one person that's been affected by the disease, and it's a very major, life-changing disease. It's of course, really in a nutshell, a condition which, once you suffer with it, you're really changing in who you were. All those years you've been growing up and developed who you are, you start to become a different person. So it's a major event for anybody. Because that person's changing, the people that they live with, spouses, so husband or wife, isn't the same person that they originally married, and then extending from that family outwards, they become a different person. So the impact is enormous. And it's also suggested that it's almost one-to-one. For every person that has dementia, there's almost one-to-one that people that consider themselves a primary carer. So immediately have a diagnosis of dementia, there's almost another person directly affected by that diagnosis. It then extends out into communities, and you can imagine that if someone's brain's not working as well, the way that they interact with the community. So I can give a bit of an example of the supermarket and the bank as common sort of interfaces in the community. So the way that someone can deal with their finances, go into a bank, get what they want. When the mind isn't working so well, that can be more difficult. If you're going into a supermarket, knowing how to interact with a person that might have dementia, but also knowing how that person with dementia might interact with that environment, it all changes, so it's all relevant. And nationally, of course, it is increasingly relevant because of the impact of those that have to become carers. It may take people out of paid work, but also more carers and people are required to help with patients that suffer with dementia and have increasing needs over a period of time. And as we know, the retirement age is going up, and therefore the number of people that will be in the workplace with a diagnosis of dementia will also increase as the occurrence and incidence of dementia increases with increasing age. So the likelihood of someone actually coming across someone that's developing dementia whilst at work is likely to be an increasing challenge. So that's some reasons why it's important. Just a bit on terminology, which often comes up when I chat to people about this, about patients and their relatives. The concept of disease and dementia, so the concept of conditions really. I use the term disease as the underlying pathology, so when people look under the microscope, doctors look under the microscope and see changes under that, that's the disease itself. So Alzheimer's disease is a cause of dementia, and but the way it manifests is the condition, the dementia. That's what we see as the person in front of us. And they don't always necessarily completely correlate, and that's one of the challenges. And there are other causes of the disease. There can be vascular disease, so blood vessel problems, blood supply problems to the brain, a bit like strokes, furring up of the arteries is a term that we often use, and that can overlap, be mixed with Alzheimer's disease. There are other causes you may have heard of: Lewy body dementia, frontotemporal dementia. They're much less common. And then the dementia. So the dementia is when those are occurring in someone. You see someone with dementia. That's what you see in front of you. And how do you actually recognise that someone has dementia? Well, essentially it's when someone loses abilities. They're no longer able to live as they were. So it's not something you can necessarily spot during meeting someone in the street or in the bank or in the supermarket, unless someone might be struggling in that situation, which you'll come on to. So you often will note it over a period of time. And sometimes it can creep up at you, sometimes it creeps up on relatives, and you actually have to get them to reflect and say, oh, how long have you been having to go in and give someone their medication? Or why have you been going in at lunchtime? Oh, they weren't eating their lunch. So often at times a moment of reflection and realisation to the point to realise that some of the problems they have. Now, of course, that change in a person's ability is in absence of a major physical reason, such as trauma, injury to a leg or something. But there are other causes of why someone may not be able to function as they were. Delirium is really an acute confusional state, whereas, say, dementia is a chronic. So acute often make them medical cause underneath it, such as infection. And things like depression, for example, are also other causes. So, but when you see this change, and if you think about people you may know, if you're seeing this change, the first question is to recognise that there is a change and that it might be something going on, and then really to raise that concern so that someone can get an assessment and ask some of these questions about what actually is going on. So, symptoms and signs. So this is obviously what we see in someone and what someone might experience. The common one we hear about is memory. Someone becoming a little bit more forgetful. Now, losing your memory is not really something to be considered as normal as you get older. It can happen, but I would generally say that not to consider it normal. And certainly, you can get a condition called mild cognitive impairment where you can get some memory problems. However, if with the memory someone is not really able to cope as they were before, that shouldn't be considered normal. So that should trigger, okay, maybe I need to get an assessment, think about what's going on. Other things, it can affect all different parts of your mind. The brain is a very complex thing. So this is just a few selections of areas of the brain that can go wrong. But if we think about running our week, running our day, what we do, we wake up in the morning, think about, right, is the milk in date? Do I have to go to the shop? When do I have to do my shopping to get all the food for the week? Who have I got to go and pick up next week? Which class am I going to? Well, someone can start losing that ability. So they might be out when you go around to meet them. Oh, we were due to meet. Or they might just forget to come and meet you somewhere. And then you might say, when you go around for a cup of tea, the milk might be off. And then you look in the fridge and everything's out of date. So those are some things that can happen. Going into new places. So you may not notice a problem when we sort of superficially go around to someone's house and have a chat. But you take them to the supermarket and they might struggle. Or the supermarket got rearranged. Don't know the routine of going around. That can cause quite a bit of difficulty. There can be more specific things like word finding difficulties. So fluency of the way sentences are constructed. So it can be difficult. So you might find that someone seems to be a bit withdrawn. Their speech is just a bit more limited. They can't find the right words for things. And naming things they have to describe around. Or that thing you sit on over there. Things can be a bit more difficult. Money, that often goes a little bit earlier, although it's more difficult to pick up these days because everything's on direct debit, so that question's more challenging, but it used to be a really nice sensitive one to pick up early, but everyone's getting much more organised, so not quite so helpful. But look out for the money. And it may not just be about planning bills, it can also be about recognising the money and how you hand over the right money and get the right change in a shop. Personality can change. Someone perhaps who was placid might become irritable or vice versa. And then mood, obviously interlinked with depression, but mood can be disturbed as well with dementia. And then there's some of these signs here. If you imagine it sort of like a seesaw or a scales of balance, that's the way I sometimes look at it. You start to lose one thing that becomes less active, and you may get a slight imbalance and overactive other aspect to the brain. Or also it may just be the way the person reacts. So if someone's not understanding the world so well and they can't express themselves in the same way, they might start to get irritable or a bit aggressive, and they may start wandering, and wandering can actually be quite therapeutic. Sometimes people become less agitated if they wander and move around and walk around, and if you stop them wandering, for example, that can cause quite a lot of distress, and we get that's a challenge I'll talk about in the hospital. Sleep disturbance as well, Again, agitation we talked about, but also hallucinations, so seeing things can be part of that. Delusional beliefs, so believing things that are wrong, that aren't actually sort of, well, they aren't true. And apathy, so that's a common one. You sometimes sort of sneaks up on you, and I see someone that, maybe from a physical point of view, where they've been having some falls, and you ask what they've been doing all day, and they often just sit in the chair, and the relatives are getting really frustrated because they're just not doing their rehab exercises, and you actually probe a bit more deeply, and you find that there's some cognitive problems, and they've just lost that drive, the drive to do anything, sort of drive to plan. And so just end up sort of sitting really, and it often manifests quite frustration and seen as laziness. So we'll move on to the disease itself, and I guess I'll refer mainly to Alzheimer's, and unfortunately there isn't a cure, which I guess we all probably know that, because you know, this, we wouldn't probably be up here if there was a cure for it, but of course there's ongoing research looking for treatments and cure. We're not able to slow the disease process itself really either. An example of a disease where we can slow the process is rheumatoid arthritis. Very successfully has drugs that can really damp down the progress of the disease, so that although you've still got the disease, it doesn't do all the same changes. But we can slow the progression of the condition, again, so maybe not change the pathology, but what we see in front of us. For some people, we can change the symptoms that they get, slow the deterioration in the curve to allow someone to remain more independent for a longer period of time. But that, drugs like galantamine, memantine, and donepezil you may have heard of. But of course, it doesn't work in everybody, and that's where the importance of individualising treatment comes about. The need to discuss what symptoms someone has, obviously what type of underlying dementia someone has, because they're not indicated in all types of dementia. And then really work with the person to make sure that you're monitoring someone for any side effects, because these drugs can have side effects, such as nausea, vomiting, sometimes some falls problems and heart rhythm problems. So they do need to be monitored, and you know, continuity of care to see how they're benefiting. So it's important. And I'll talk about, although I've called it indirect vascular risk factor treatment, what on earth does that mean? Well, you may have heard recently there was a report that perhaps there was a less than expected occurrence of new dementia cases in men. And some of the thoughts are perhaps along the lines that the vascular risk factors, so this is furring up of the blood vessels in the brain, so high blood pressure, diabetes, alcohol, smoking, those conditions that cause heart disease and strokes. So if you treat those conditions, healthy lifestyle, exercise, good diet, then actually that can have a sort of indirect effect and is very important. And as you've heard, there's often a mixed and overlap between Alzheimer's and this vascular. So actually, although I haven't put it as direct, treating those underlying blood vessel problems are really important. Your general well-being, health is an important sort of message, I think, that I would put out there. There we are. So, what are the challenges of the condition itself? Well, as you've seen by the number of symptoms and signs, they are multiple, and that is a big challenge. And so, you can't say that this person with dementia, I know exactly, I don't even have to see them, I know exactly what difficulties they're going to have this, that and the other. So you can see that they can have any one of those problems that I showed on the slide before, or very few of them. And within that, the severity of the way, the deficits that that person might have can vary as well. Some might have severe memory problems, some might have mild problems, some person might like to wander around and get agitated if you want. It's all very individual, so it's very difficult to predict. So it can vary between people. It obviously varies over time longitudinally because it's a progressively deteriorating disease over time, but it can vary within a smaller time frame. Someone might be better in the morning or the evening, so everyone is individual. And then of course in place as well, as I mentioned, going out to the supermarket, they might be very different in a busy place or with some unfamiliar environment. Someone's needs or difficulties could be very different. And of course, when we're sort of leading on to the hospital type bit of the talk, if there's a stress. So a stress might be going out to the new supermarket, but a stress also might be a medical condition, or it might be a fall. Is there a medical condition? It could be any sort of event really. A bank statement saying you haven't paid the bill. I mean, and anything can be a stressful situation that can make someone change. So, and you know, that is important very much to recognise, because if someone's coming into hospital, that is a very important event, no matter whether we think someone actually has a medical condition or not. And trying to manage someone through that difficult time is what the challenge really that we're trying to get better at, and hopefully are getting better at. So what's been done at Hampshire hospitals? Well, firstly, to do anything, we've got to recognise that someone with dementia is coming into hospital. So there's a system that to do that, to ask the question if someone is known. But also we have a system to look for those, as we know, about half the people with dementia may not have a diagnosis and a label. So therefore we have to have a system to look out for those that might actually have dementia but not been picked up. So we have that. It's important to know who the person is in front of us. As I said, we can't predict it. So that's where the This Is Me from the Alzheimer's Society, the document that just really gives the story of the person, who they were, who they are, how best to manage, to interact, to communicate preferences for if someone can't represent themselves as well as they might like to because they're poorly, so that we know this is someone's backstory, this is who they were. And then also the importance, as I mentioned, almost one-to-one with a direct carer, with someone with, a spouse, someone that really knows that person. We were one of the early adopters of John's campaign, which is really just about saying to a carer, a relative, to say, look, I'm important in this person's care. We work together to provide, to basically get by each day. So I need to be able to represent and help you understand, my husband, my wife, whilst they're in hospital. And also, the relative needs to say, and you need to tell me, or we need to help with the relative, say, this is what's changed, these are our challenges on the ward. And I mentioned wandering, and of course, wandering, if you try and stop someone wandering, it can make them agitated, make them worse, but obviously you've got to balance that with the risk when someone might be poorly, of the fact that they may be at risk of falling over, and that's one of the big challenges that we have, is how do you keep someone safe, but allow someone to be able to mobilise, to recover, to remain strong, but not risk the potential fall, head injury, fracture. And it's really important because there's no easy answer to any of this, but it's important to have that communication and dialogue, and for everyone to realise what the challenges are when we're managing patients in a hospital, unstable setting, because someone can change a lot. And to help the nurses and doctors with develop pathways of care, which are very much symptom focused, so that you can sort of say, well, this person's agitated, what's the best standard of care that we should be providing? How do we get it right for this person? This person's wondering, what is the right thing? Who do we need to make sure we're involved? What do we need to rule out? This person's more confused. Have we done everything that we can do to look for things that are treatable? So that's really encouraging. And to underpin all of this, training, education. I learn new things about dementia almost every day, really see things from different perspectives, hear different stories. There's always learning to be had. And it is really complex, it's really difficult, as I've hopefully sort of illustrated. Really difficult. So helping understanding and education is really important, and we're very lucky to have an excellent team of specialist nurses. And they really can facilitate things, which I can see Rachel there at the moment, really help underpin the training and education, and not just classroom, what should we do if, but this is real time, really useful, sort of apprentice style, shop floor stuff, They can phone up Rachel and they can say, I'm not sure what to do, can you help? So it's immediate benefit. We've got a challenging situation, and so someone can learn real time to affect change for that individual, rather than having to say, what could we have done better last time? Actually do it better from there, and then learn and take that learning ongoing. So it's really, really, really good. Just coming to the end, I think that's the last one. A bit about the future. Well, what do we think? We're all familiar with physical and visual disabilities in the way that society has adapted our environments across the board, in supermarkets and banks and so on, probably here, being able to get up here and so on. And really that's the way that I see it. The environments that we interface with people is going to be another big area where we're going to see, we see the wheelchair sign for the loos and the access, we have braille, we have talking lifts. Society will alter itself, have to simplify itself, have to change, have to respond, depending obviously on the demands on any environment. You know, banks will have to, obviously do have to know about things like power of attorney, what to do if you're worried about whether someone can actually sign that check, you know, financial abuse, all those sorts of vulnerabilities, and also have environments to facilitate that. And we've heard various things like slow lanes at the supermarket. I'm not sure it's a great term, but there's some response to the idea that there are some additional needs. I think quite like the idea of a slow lane actually. But you know, so the society will probably change like that, and have to look at every environment with cognitive impairment in mind as well as physical and so on. And of course, education and understanding, not just in hospital but everywhere. All of us, to understand what happened, because it's, you know, it'd be common that we'll come across someone. We have to know. You know, if you bump into someone and they're lost, it's in the street. What's the plan? What should we do? What could we do? But having said that, you know, we'd like the treatment. We'd love to have a cure, and that's somewhere in the future, perhaps, or at least some treatment, some disease modifying. But just underlying basic care, good basic care, communication, understanding. That's something that we can do now, we can do tomorrow, and I really think that is something that's very exciting about getting right, and hopefully we do that well and are improving all the time, I would hope. And I've certainly seen a fantastic critical mass of improvements and development over the last few years with regards to the interface between hospitals and the community. So that is something that we can do now, and it's not directly about changing the disease, but it's about providing better outcomes for people and patients with dementia. So there we are. I think I've said enough.